Hello and welcome to Talking Points. I'm Dave Kelly, Director of Advanced Media Production at Cal State Long Beach. Today we'll be talking about maintaining quality of life during the aging process. I have two guests with me today. The first one is Dr. Stephen Castle. Dr. Castle is a professor of geriatric medicine at UCLA. He is also the clinical director of geriatrics for the VA Hospital of Los Angeles, and additionally, he is an appointee to the California Commission on Aging. My other guest is Patty Mouton. Ms. Mouton is the Vice President for Outreach and Advocacy with the Alzheimer's Association of Orange County. Welcome, Stephen, and welcome, Patty, and thank you for joining us on Talking Points.
It's great to be here.
Yes, thank you very much.
And as we get started, we should probably establish some relevant statistics about aging in America because there is a pretty dramatic demographic shift going on as we speak. If we go back to the year 2000, about 13% of our population were over the age of 65. But every day now, every day of the year, about 10,000 people are turning 65. It's because of the aging of the baby boom generation. And by the time we get to the pivotal year of 2030, about 15 years from now, we'll have 72 million people in that age bracket above 65. So from 13% of the population to about 19 or 20% of the population, or about 1 in 5, will be senior citizens. So Stephen, I'm going to start with you. As a physician, what kind of impact will this demographic shift have on our society, and are we ready for it?
Yes and no. I think the other aspect of the demographics is the decline in the birth rate. And so the people that in 20 years that we're going to need as caregivers, there's shrinking numbers, and that's both formal and informal. So, being able to be ready to take care of that is important. I think on the other hand, we're living healthier. So we're, in a lot of respects, we're healthier than in years past, and we're staying engaged and more active. And there's a lot of evidence that retirement, it looks a lot different than it did a few years ago. So I think there are some positive things that are happening, but there's a big demand that's coming that we need to take steps now to help us get ready.
Okay, and we know that healthcare is a really important aspect of the aging process. We need to have access to good quality healthcare. But Patty, I'm going to turn to you and ask you about what we need to do long before we reach the retirement age, because we want to enjoy those golden years. We don't want to just live out the last 20 or 30 years of our lives. We want those to be full and robust years. So what can we do in those previous decades to get us ready for that?
Well, many of us like to believe that 60 really is the new 40, and so aging well starts when we're very young. We have to do things like watch our diet, not drink too much alcohol. We have to make sure we stay mentally engaged and that we're building up cognitive reserve and keeping our brains really active. We want to make sure that we manage things like diabetes and that we push off symptoms of type 2 diabetes, and we want to make sure that we manage all of those things nutritionally, socially, intellectually, and keep ourselves as vibrant as possible as early as possible, because that's really what's going to help us age well and be able to live very quality lives.
And Dr. Castle, as we talk about the continuum of care and we talk about quality of life and maintaining that quality of life, you see this with your patients. They start out at 65. They're different at 65 than they are when they're 80. That's just the normal process. But from your perspective, how do we assess that quality of life through the quality of care that we're giving?
So quality is usually something you know when you see it, but it also can be measured. I think one of the important aspects is satisfaction. So satisfaction with your healthcare providers, that they're answering the questions, that you're able to get to them when you want. But there are other markers too, that certain things should be done based on evidence that if you get your colonoscopy done, you get your vaccines, you get things done, that those also relate to quality. Control of chronic diseases, hypertension and diabetes, those are big ones.
And Patty, I'm going to ask you then about the folks that you come in contact with at the Alzheimer's Association. Many times when you meet families, they have parents or other loved ones that are just entering the various stages of Alzheimer's and dementia. For the patients, how do you measure or assess quality of life? And for the families, the caregivers who are involved in this, how do you assess their quality of life?
That's a complicated question, Dave. What I see in many families is that the person who's been diagnosed with a cognitive impairment really wants to ensure that they maintain dignity, and sometimes that's defined differently for different people. They want to ensure that they're not a burden on their family members, and sometimes they're concerned about that. So having a plan in place, looking at what their care options are going to be, having family caregivers be very well prepared, understanding the financial plan and what kinds of resources are available now and are going to be available in the future, that helps to create some peace of mind, and that then adds to quality of life. So relaxing about the diagnosis is very hard for families, but if they have a good plan in place, and if they understand the disease and they understand what can be done to make people feel better longer, then people do very well.
And speaking of having a plan in place, we need to talk about mobility, because mobility is a key measurement of quality of life. And we can talk about mobility in a couple of different contexts. One of them is personal mobility, or the ability to actually physically get up out of a chair and walk to the kitchen and do things of that nature. But there's also the larger issue of transportation, getting around the community. And according to a study I read, most people outlive their car keys by 6 to 10 years. And if that's the case, there needs to be some planning that takes place for that final decade. Stephen, what do we need to do to get that planning process started?
So, and mobility and your own mobility and decline isn't something that's easily measured like a blood pressure or a cholesterol. And so very often, it's only until you engage a task that's beyond your capability that you suffer a fall. And so part of it is educating physicians and providers of how to measure and assess changes in balance and help patients have more awareness that there are changes. And then putting in place some basic things, what I call low-hanging fruit, to really help with that mobility. You know, paying attention to footwear, and that going barefoot is 14 times more likely to fall, using mobility aids, having adequate lighting, knowing whether you have troubles with your progressive lenses when you're going downstairs. And then the exercise that's needed to maintain your mobility. We don't run across stepping stones like we did when we were younger, and so practicing and adjusting and learning how to take advantage of what sensory systems you still have and which ones are impaired. So it's more awareness of what your limitations are. The driving issue is a hard one, and I think a lot of it, what I do is educating the passengers and really kind of asking the passengers for some red signs, some red flags. A lot of that is not remembering where you are in familiar places, not paying attention to stop signs or traffic lights, and restricting the area that you drive. That's a big red flag. Now, it's a good thing to do that in some respects, after certain medications or at nighttime, but when you only begin driving just to the doctor's office, just to church, just to your favorite restaurant. And so that's often a question I ask, is what's the longest trip you've taken in the last year, to kind of get a sense of that.
And Patty, in your work, working with the Alzheimer's Association and families, is the battle over the car keys a big one?
It's one of the worst problems that families experience, and one of the biggest grounds for fighting. People don't always understand that they're impaired and that they shouldn't be driving. And most people don't get a good diagnosis of a cognitive impairment like Alzheimer's disease until they're well into the disease, maybe 4 or 5 years. So it really is important that we start looking at alternatives to everyone self-driving everywhere, and people watching out for one another. Like Dr. Castle said, if you sense that one of your family members is not so good behind the wheel anymore, then the time to intervene is not when they have an accident, it's beforehand.
And one of the tips I learned from the Alzheimer's Association is to go to the oldest grandchild to have that conversation. You know, Grandma, I really care about you, and driving is a scary thing, and I really want you to go get tested, and use the oldest grandchild as
Yes.
the key go-to person to help with that conversation.
It's a great barometer. And in fact, one of the things we ask adult children of people who have cognitive impairments, when they're having this tussle over the car keys, is would you allow your child to ride in the car if mom or dad or grandma or grandpa was behind the wheel?
Right. Well, the reason why people want to drive is because it gives them a sense of independence.
Yes.
And so now we're talking about that next level of independence. If I can't drive, now I'm dependent upon the kids, the grandkids, neighbors, friends, etc. So now we need to talk about independence, or some sort of medium ground between full dependence and independence, and also the instrumental activities of daily living, what they call the IADLs, which is banking, which is preparing food, shopping, getting to the doctor, as you mentioned, Dr. Castle. What about that, Patty? What kind of conversation do you have to have?
Well, you have to look at safety first. And sometimes that's where families really get tied up, is we want grandma or grandpa or mom or dad to be safe, but they have to be able to make their own decisions, because that's a huge measure of quality of life. So how are they safe, and how much of these decisions can they continue to make, and what can they manage? Usually people who are starting to have cognitive impairment notice when they can't balance their checkbook anymore, or the bills pile up, or their cable gets turned off because they've missed paying a bill. We have to look at medication management, because lots of times when people go to the ER, it's not because they're terribly ill, it's because they have either missed or doubled up on medications inappropriately. So safety first, then look at how people can make their own autonomous kinds of decisions, and then what can we put in place that just gives them a little support? Maybe in-home care a few hours a day, maybe somebody monitoring that they've got groceries in the refrigerator or making a meal for them, maybe Meals on Wheels, but little supports to start with before we have to get to a huge transition in where they live and how they're cared for.
And we just have about 30 seconds before we go to the break, but Stephen, when you have conversations with caregivers, what are they telling you about the independence versus dependence issue?
It varies, and sometimes the caregiver is impaired too. So that's often a challenging area. But I think it's by breaking it down into specific tasks of what is it that they're having troubles with, where's the rubber hitting the road, to try to get at what their functional limitations are. And then you can look at, if you're going to use medications, to use those same measures to know if it's getting better or worse, and whether you should try other options.
And on that note, we're going to go to the break. When we come back from the break, we'll talk about what actually causes Alzheimer's disease. Stay with us.
Make a difference in someone's life. With the ever-increasing amount of senior citizens in the United States, the need for counselors, caregivers, advocates, and product developers continues to rise. Be there for someone and see how rewarding it can be. You can become part of this exciting field with a degree from Cal State Long Beach.
Welcome back to Talking Points. I'm Dave Kelly, Director of Advanced Media Production at Cal State Long Beach. My guests today are Dr. Stephen Castle and Patty Mouton. Today we're talking about maintaining quality of life during the aging process. When we went to the break, we were talking about what it takes to make sure that an elder patient, a loved one, a parent, is able to take care of the instrumental activities of daily living. And we know that as the onset of Alzheimer's or dementia kicks in, those issues become more challenging. And so, Dr. Castle, I wanted to address what the root causes are of Alzheimer's and dementia. And if we take a look at it from the big picture perspective and go from big to small, we start with the brain. The brain has a complicated series of neural networks within it. Within those neural networks, we find microtubules and microfilaments and neurons and so on. Within that environment, we have proteins and amino acids that are acting. We have what's known as a tau protein, which has been indicated as problematic in the onset of Alzheimer's. If you could kind of lay that out for us briefly and let us know where we're headed with this.
Yeah, so first of all, Alzheimer's is one type of dementia, so I want to make that clear. And in Alzheimer's, there's a loss of neurons, the nerve cells in specific areas of the brain. And it comes on over a long period of time. And there's two main pathologies going on. Is some of the proteins that are produced on the surface of the nerve cells, they get clipped. And depending on where they get clipped, they then can reassemble in what we call these pleats of beta amyloid. So it's protein junk that really accumulates in the cell and results in an inflammatory reaction that leads to the death of the neuron. The other thing that's going on, as you mentioned, is the tau proteins. And the tau proteins, they make little like cables within the cell that allow the neurons to have those long dendritic projections to connect to other cells. And those proteins get phosphorylated, which changes their chemical nature to the point that they no longer aggregate in the cable, and instead they just become amorphous cell, and so you lose the ability of certain cells to connect with each other. The other key point is the other main type of dementia is vascular dementias, which is due to either one large stroke or many small strokes that can affect different parts of the brain, and there's often an overlap between the two.
And when you talk about phosphorylation, from what I understand, hyperphosphorylation is when those tau proteins are out of control and we have maybe as much as 3 times the amount of that in the bloodstream as what would be normal.
In the cell itself, in the
cell.
nerve cell itself.
Right, okay. So Patty, when you have these diagnoses about Alzheimer's where there's brain functionality is now slipping into dementia, there's a spectrum from early onset to later onset to final stage. I know you've experienced all of those at the Alzheimer's Association. What are people telling you about the frustrating nature of taking care of their parents along that spectrum?
Well, sometimes it's really hard because the diagnosis doesn't come until maybe the person has been exhibiting some symptoms for a number of years. But we see people who get a diagnosis when they first understand that they have some functional problems, and that mild cognitive impairment very often does convert into Alzheimer's disease. And it's scary for people, and it causes some depression, and it causes families to have to really regroup and look at what the next 8 to 10 years are going to look like. The average person, their lifespan from diagnosis of Alzheimer's disease to their end stage and demise is about 8 to 10 years. So families have to look at how are we going to manage this. And it's scary, but as I said, a plan and understanding what's going to happen and having families kind of get together and figure out whom in the family is going to manage things, that makes things easier.
And as we talk about different strategies to engage an Alzheimer's patient, there are a couple of things that I can think of that at least anecdotally have done well, and there's even a scientific study now that seems to support this, and that is if we utilize music and if we have pets involved, those can bring Alzheimer's patients out of their shells. Could you talk to us about that a little bit?
Oh, sure. There's many, many ways to really engage someone who has a cognitive impairment, no matter how impaired they are or how profoundly the Alzheimer's has taken hold. So music therapy really helps. Oftentimes, a musical memory, a special song, something that really has resonated with that individual and carries with it some deep emotion, stays with them a long time. So while they may not be very verbal anymore, if you start playing the music to a song that they loved, they'll be able to sing along with the lyrics. And that really does brighten them up, and it makes everybody feel good. Another wonderful, wonderful aspect of care is using pet therapy. Animals of all kinds, particularly dogs, that really seem to engage with the individual. And recent studies now talk about how when you look a doggy or a puppy right in the eye and you have that contact eye to eye, it creates an opportunity for a bonding hormone in the brain to be released. So that oxytocin that typically makes mothers bond with their children and makes loved ones care about one another and feel that loving kindness and bonding, we know can happen with animals. So people calm down, they pet the doggy, they'll talk to the dog or to other animals, but dogs frequently seem to be the most beneficial.
And Dr. Castle, what about this oxytocin that's released with this emotional bonding? How does that help?
Well, it's a hormone that's released in the brainstem, and it results in that bonding. So I think it's kind of the face-to-face, and in the VA, they use the mnemonic to listen, respect, comfort, and redirect. And part of the listening is to get that eye contact, and then reassurance, calming, listen to what they're saying, and then redirect. By stimulating the vision, you're increasing the oxytocin levels. That's the theory.
Right, and that's the study with the dogs. That's what it indicated. It was that continual contact, eye to eye, with the dog and the person that was being studied. And I guess in both the dog and the person being studied, they saw elevated levels of the oxytocin hormone being released. Okay, let's talk about caregivers being more sensitive to the environment in which an Alzheimer's patient lives. When I say environment, I mean the mental, cognitive environment.
Sure.
And we know that a lot of Alzheimer's patients have lost short-term memory, but longer-term memories are still pretty strong in a lot of them. And so that means that grandma might be living in 1946. She might be talking about 1952 or something along those lines. How do we be more sensitive to that as caregivers?
Well, we enter into the moment that the person with Alzheimer's or related dementia is currently in. We get with them and we get alongside them. And if they are thinking about something that happened in their childhood or young adulthood, then we want to ask them about it. We want to make sure that it's a calming kind of memory. If it's something frightening, we want to let them know that everything's okay now. The situation's been resolved. And we want to engage them in it. So rather than correcting and saying, no, this is 2015 and you're in Los Angeles now, you want to go with it and say, well, tell me about what it was like living in Kankakee during World War II. Or tell me what it was like when you first got married and you were going off on your honeymoon to California. You want them to be able to talk about that experience, especially when it's a positive one, and be in the moment right with them.
So in a sense, we're asking caregivers to participate in the time warp of sorts.
Yes.
At that time.
Absolutely. And it can be really fun, and many times families then hear stories that have never been part of family folklore when grandma can then talk about something that happened to her in her childhood, or when they got their first car, or something really special about what happened that she can remember way, way back that is also tied to strong emotion, and those memories will be retained and can be very entertaining.
So we're trying to capitalize on the good feelings.
Yes.
Right. Okay, and Stephen, when we talk about making decisions for aging parents, it's often the children, of course, that make these decisions. But what children want for their parents is safety first and foremost. And that may be good for the children to have that peace of mind that their elder parent is safe and secure. But maybe it's not the best thing for the patient if that environment is not particularly warm and supportive in the way that that patient would like. What about that?
No, you're right, and part of it is physical activity. So, keeping a person with dementia active is the best way to prevent progression, and it's also to prevent it from its onset. And we often become afraid to allow people to be active because of the risk of falls. So I think part of the environment we have, wherever they are, is to try to maintain that sense of physical activity and track it. So we have on our phones now how much we walk a day, and we look at that and we try to walk more. And I think we need to engage in those sort of tasks with our older adults. And then the interaction. So in the nursing home setting, which is a traditional nursing hierarchical setting, their ability to relate to the patients with Alzheimer's is much different than we see in community-based settings. where they're much more able to live in the moment and not kind of chastise the older person for not remembering they just had lunch. And so I think some of it is the training. And what I see is, even though the care workers are the same level, there's a big difference what we see in nursing homes compared to what we see in community-based adult services.
And so, Patty, that seems to suggest that we need to think more about home and not so much about nursing when we talk about nursing homes.
Exactly, a home-like environment. Even if the person has to be placed outside of their home, make it as home-like as possible and have as much person-centered care so that we are managing that person's daily routine according to what they like, as opposed to what the structure of a nursing home needs to be. So community-based care, adult day health care, these kinds of programs are really wonderful and really do help to have people age in place a little bit more successfully.
Absolutely. We've just got about a minute left. So I'm going to give each of you a parting shot here, but you only have about 15 seconds each. So we'll start with you, Dr. Castle. Where are we in terms of finding a cure and better treatment?
Well, we have a long way to go, and the analogy I make from Dr. Bredesen from the UCLA Alzheimer Center is that if your roof has 36 holes and you plug one, it's still going to flood when it rains. And so that's a lot of the socialization, the activity, proper diet, control of chronic diseases, avoiding additional head trauma, that we have to plug all those holes, and that if we do that, then when we start looking at specific treatments, we'll be able to look at the effect and see the benefits sooner. So I'm hopeful it's there. It's around the corner.
It's around the corner. Patty, just a few seconds. What do you think?
Reduce your risk, eat a very healthy Mediterranean diet, don't bash your head in, and stay as active physically as you possibly can. And those are some of the keys to reducing your risk of developing cognitive impairments.
And thank you both for joining us today on Talking Points.
Thank you for inviting us.
Thank you.
Absolutely. And thank you for joining us for this edition of Talking Points. Join us again soon for our next episode. Until then, I'm Dave Kelly. Have a nice day.